Okay, so thank you everyone for being here today. My name is Jessica Heslop. I am a program manager with CRISP and I help lead the learning system. And today is the first of a series of 4 presentations related to the Maryland Model Analytics project. For some background, this project was started the very end of 2021 with an RFP that was sent out to multiple vendors that we were looking to evaluate specific aspects of the total cost of care model. Some were looking at specific analysis questions that we presented. And then this particular analysis was actually brought up through the vendors in sort of like a vendor defined question. And it is something that we thought would be very valuable and aligned with some of the goals within the total cost of care model. So with that said, we worked with Acumen over, I guess 2 years, a little less, and helped them with this investigative analysis question. They worked with stakeholders and really just analyzed kind of care redesign, potential best practices, and things like that associated with the question. So with that, I do want to turn it over to Amy Wyndham from Acumen. And she will be presenting on the outcomes and costs associated with evidence-based treatment for the first episode, Psychosis. We do ask to hold questions or please put them in the chat and we will help facilitate them towards the end. And we can also, of course, take people off mute if they would like to ask questions at the end as well. So again, thank you. And Amy, whenever you're ready.
Great, thank you, Jessica. Let me get the slides pulled up here. Awesome. So as Jessica mentioned, I'm Amy Wyndham. I'm a senior policy advisor at Acumen LLC, and I appreciate the opportunity to present these results to you today. As Jessica said, the focus of the talk is on, or the analysis was outcomes and costs associated with evidence-based treatment of first episode psychosis. And I have a couple screens going on here, so hopefully they will cooperate with me this morning. There we go. Okay, so just for a little bit of background on schizophrenia and psychosis, schizophrenia spectrum disorders include schizophrenia, schizophreniform disorder, unspecified psychotic disorder, schizoaffective disorder, and brief psychotic disorder. They are very difficult to treat and very often result in severe functional impairment. The central feature of schizophrenia spectrum disorders are psychotic symptoms or psychosis, which include or can include any kind of combination of hallucinations, delusions, disorganized thinking or behavior, and also negative or catatonic symptoms. The symptoms often occur with other psychiatric conditions such as mood disorders or autism, spectrum disorders, personality disorders, and substance use disorders. So it's common for them to be comorbid with other types of with other types of mental health conditions, as well as other physical health conditions. So the prognosis for individuals with psychosis is poor, and the long-term effects can include cognitive deficits, physical health comorbidities, functional impairment, risk of suicide, and reduced life expectancy. So the research has found that longer duration of untreated illness results in worse outcomes, as well as greater health and societal costs. So that is, the longer you wait to initiate care, the worse outcomes can be for patients. We also have observed, or the research has reported, racial and ethnic differences in treatment initiation and course that compound the disparities in outcomes related to FEP. So like other conditions and other mental health and other types of conditions, we do observe some pretty serious racial and ethnic differences in outcomes. And some of these are attributed to the fact that that Blacks tend to initiate treatment at a later stage of illness when their symptoms are more severe and there's greater functional impairment. They also are more likely to be prescribed what are referred to as first-generation antipsychotic medications. These older medications have more serious side effects and adverse effects on patients' physical health and compared to some of the newer medications. And this contributes to more serious physical health comorbidity, as well as higher costs down the line, and exacerbates the racial and ethnic disparities. Research in recent years has found that early and comprehensive treatment of psychosis can significantly improve patient outcomes. And multi-component treatment programs, which are referred to as coordinated specialty care, have been found to positively impact a range of clinical and social outcomes, including reducing symptoms, improving functioning and quality of life, increasing medication adherence, and reducing hospitalizations. So coordinated specialty care, which is referred to as CSC, it's not one specific program, but there are multiple different kind of iterations of CSC, but primarily, typically they include, the CSC programs will include pharmacotherapy, case management, medication management, individual and family psychoeducation and therapy, and supported employment and education. So very comprehensive care initiated early is the idea. Maryland provides, or at least at the time of these analysis, and Maryland was providing CSC programs in Baltimore City, Baltimore County, and Montgomery County. So we designed the study to examine use of CSC for first episode psychosis based on service utilization patterns captured in administrative claims data. Our initial aims were to estimate the proportion of individuals with FEP who receive services defined as CSC, examine variation in the use of CSC across geographic locations across the state and across population subgroups. And finally, the third goal was to examine associations between CSC and clinical outcomes, specifically emergency department use and hospitalization. The research questions included, I'm just going to read them here for you, so I hope it's not too tedious, but the research questions included: what is the prevalence of psychosis among the study population? What are the characteristics of enrollees with FEP? What percentage of individuals with FEP receive various types of behavioral health care ranging from less to more intensive services? How does behavioral health service use for FEP vary by age, sex, and geographic region of the state? And what enrollee characteristics and patterns of behavioral health service use are associated with emergency department use and hospitalizations in the year following an initial FEP diagnosis? We use private insurance enrollment, claims, and pharmacy data from 2016 through 2019 for Maryland's all-payer claims database. We initially planned to analyze Medicaid and Medicare data. However, the rates of FEP are very low in the Medicare population in Maryland, and we were not able to get access to the Medicaid data. So we focused on the private insurance population, and including enrollees ages 15 to 30 with a psychosis diagnosis, because we use age 15 to 30 because we're trying to capture the first episode, and we can't completely identify the first episode in claims because we don't have the person's entire history, and also we are limited to diagnosing and identifying psychosis among people who actually come into services. So we use a lower age frame to try to narrow in a little more closely on what, for the most part, would be either a first episode psychosis or still very early onset psychosis. We identified the enrollees with psychosis using the claims data from between 2017 and 2018, and use the date of the first encounter to establish the beginning of a psychotic episode. And then to establish a first episode, we subset the sample to enrollees who didn't have any claims for a primary psychosis diagnosis in the 1-year period prior to the incident visit. Okay, so our first task in the analysis was to examine the claims data and determine if we could, in fact, actually define CSC using the claim. So our idea was, our initial goal was to examine this specific type of treatment to see if individuals who were receiving this more intensive types of treatment had different patterns of outcomes, et cetera. And so to do this, we classified the procedure codes in the claims data as outpatient treatment, emergency department use, or hospitalization. And then we further broke down the outpatient treatment into office visits, psychotherapy, care coordination, intensive outpatient treatment, substance use disorder treatment, alternative treatments and medication management, and residential treatment. We also use the pharmacy claims to identify prescription fills for antipsychotic, antidepressant, and anti-anxiety medications. And so just as a reminder, what we're trying to identify with the claims is this constellation of services that would identify CSC, which include pharmacotherapy, care management, medication management, therapy, and supported employment and education. Okay, so in the private insurance claims, we weren't able to, we knew going into this it would be difficult to specifically identify CSC, but but we wanted to see kind of what types of services we could identify. So, for example, in the private insurance data, the supported employment was not coded directly. We didn't find any specific codes for supported employment. Sometimes you do see that in Medicaid and other types of data, but we didn't see it in this data in the Maryland claims data. So we also saw some of the components. So for example, we saw medication management, but it was coded too infrequently to kind of classify it as a specific type of treatment. So we opted to create categories of outpatient service use that reflect typical patterns of care that range in intensity. So for the analysis that we'll get to kind of near the end of the presentation, we categorize the outpatient use based on kind of traditional office-based care, and this did include pharmacotherapy. So nearly all of the sample did have prescriptions for medication. So the kind of lowest level is just office-based care with pharmacotherapy. Second level is office-based care with psychotherapy. And then we also looked at the category of high intensity care, which included more intensive treatment, such as care coordination, residential treatment, or intensive outpatient treatment. And so just to recap, the study involved a descriptive analysis of patterns of service use by private insurance enrollees with first episode psychosis, and examine clinical outcomes in relation to the patterns of service use. So I'll summarize the results of the analysis, and there are basically three sets of results that I'll show you. The first set of results are characterize the sample by demographic characteristics, behavioral health comorbidities in Maryland region. And the second set report the number and percentage of enrollees with psychosis and with FEP who receive different types of treatment. And finally, I'll present the results of a multivariable logistic regression models that estimate the odds of emergency department use and hospitalization in the year following an FEP diagnosis. And I want to emphasize that this is a descriptive exploratory analysis, and we are interested in understanding the patterns of service use across the state. And we're not attempting to evaluate outcomes related to CSC or any particular type of treatment. Okay, so moving into these descriptive results, we first looked at the characteristics of the total sample, which included private insurance enrollees ages 15 to 30, and compared the characteristics of the sample of enrollees who had a psychosis diagnosis. Total 931,617 enrollees met the eligibility criteria for the study. And of these, 3,209, which is 0.34%, qualified for a psychosis diagnosis during the time frame of the data. Approximately half of the eligible sample were male. However, males were slightly overrepresented among enrollees with psychosis, so around 55%. Also, the more populated regions of the states, specifically the capital region, which are the counties that border DC, had slightly higher representation of enrollees with psychosis compared to the other regions of the state. We looked at as I described in the introduction, we were interested in looking at potential racial and ethnic differences in the patterns of care, but unfortunately the data on race and ethnicity were largely missing from the sample, and so we were not able to do any additional analysis looking at racial and ethnic disparities and patterns of care. Okay. As would be expected, we did see high rates of behavioral health comorbidity. So in the overall sample, just under 10% had of the total sample had a mental health disorder, and about 1.4% had substance use disorder. However, in the sample with psychosis, you see much higher rates of other mental health conditions, over 80%. And 34% had a comorbid substance use disorder. Okay, and so now moving into the examination of the patterns of treatment, this is treatment in the first year following the first episode psychosis. So to identify the enrollees with the first episode, we started with the full sample of 15 to 30-year-olds. Then we identified those among that set of individuals who had psychosis, and then we further narrowed it down by restricting to individuals who were continuously enrolled in the year prior to their encounter. And we just selected individuals who had a year clean. So technically, this may not be their actual first episode of psychosis, but it is within a year of having no services related to no services with a psychosis diagnosis. Okay. And so what we see is that nearly all of the enrollees received some type of treatment in that year across our regions of the state. Psychotherapy use was considerable, 68%, but was slightly higher in the more rural areas of the state. However, intensive outpatient treatment was less common in the rural areas compared to the capital and central regions, and you see that here. So you see intensive outpatient use more prevalent, more common in urban areas, and also residential treatment. Whereas in the rural areas, they're still getting significant levels of services, but it's a little bit higher office-based and psychotherapy. Also notable, and just keeping in mind that the prevalence of substance use disorder among this population was 34%. Only around 4% of the sample received specific substance use treatment, and that means they had services that were coded with a primary diagnosis of substance use disorder. It hopefully is the case that their substance use is being addressed in the course of their other treatments, but it wasn't coded as specific substance use treatment. Okay, so looking at the other characteristics of treatment, there were some sex differences in terms of the types of treatment that individuals received in the year following their care. Females were slightly more likely overall females were more likely to receive most types of care. In particular, 74.5% of females received psychotherapy compared to just 62% of males. As I mentioned, substance use disorder was more common. Males were more likely to receive substance use disorder treatment compared to females. There were differences in the patterns of medication used by sex, with females more likely to receive antidepressants and anti-anxiety medications, but less likely to receive antipsychotic medications. Okay, so you see that here with females and this, there's we can't really say what's driving the differences in these patterns, but just in terms of observing the patterns of care, females were more likely to be taking anti-anxiety medications and antidepressants, and less likely to be taking antipsychotics, even though these are individuals with primary psychotic diagnosis. Okay, similarly, there were some differences in treatment types by age category. Enrollees in the lowest age groups, the age 15 to 18, were least likely to receive antipsychotic medications and most likely to receive psychotherapy. Intensive outpatient treatment was more common among enrollees aged 15 to 18, whereas residential treatment and SUD treatment were more common in the older age groups. And so I'm just not going to go too quickly. I'll give you a minute just to kind of look at those results, because there's a lot on the page. So again, across all age groups, any kind of treatment is very high, but there were some differences. For example, with the older age groups, 26 to 30, more likely to receive substance use treatment, residential, et cetera. And then the lower age groups still tending to receive antidepressants, and you see kind of the age differentiation in terms of antipsychotic use, with the older age groups being more likely to receive antipsychotics. And so this is again across this is individuals with the first type of psychosis, and obviously looking at the numbers, it's likely that they're receiving. Some of them are receiving kind of multiple types of different types of medications. Okay. Moving on to looking at patterns of service use in the year following their diagnosis. So this is taking it's the percentage of enrollees with the diagnosis who had ED visits in the year following their diagnosis. So we wanted to know if it looked like there was any descriptive association with the outcomes of emergency department use and outcomes in the year following the diagnosis. So we separated out the first month. Could have a little timeline here. So the person gets their shows up with claims that indicate that they have a psychosis diagnosis. We looked at treatment. We looked at treatment, what type of treatment they received in the first month of their diagnosis, and then looked in the subsequent year to see whether or not they had emergency department visits or hospitalizations. Okay, so what we see are that the ED visits were most common among enrollees, the younger enrollees, ages 15 to 18, compared to the older enrollees. And what really stands out here is that we see having the comorbid mental health disorders or substance use disorders is associated with a much more likelihood or prevalence of having an emergency department visit in the year following their diagnosis. Okay. Okay, we did not see differences in emergency department use for enrollees based on the types of treatment that they received in the month following the diagnosis. However, enrollees with office-based treatment in conjunction with psychotherapy were more likely to have ED visits, whereas enrollees with intensive treatment post-diagnosis were actually less likely to have an ED visit. So there's not a whole lot of individuals in this category, but the enrollees who received intensive treatment were less likely to have an ED visit in the following year. There didn't seem to be any differences in terms of antipsychotic medication use. ED visits slightly higher in terms of for those who received just office-based care and office-based care with psychotherapy, and a little less likely among those who received intensive treatment. Okay, looking at inpatient admissions in the year following the diagnosis, We see just 2.3% of enrollees had an inpatient hospital admission following the diagnosis. This is a very low rate of admissions, I think, for people with a pretty serious diagnosis. So the prevalence of having admission after that in that year following the diagnosis is pretty low overall. However, there were some differences in terms of the characteristics of the individuals. Inpatient admissions were higher among the older age group, and again, higher among individuals like ED use. The inpatient admissions were higher among individuals who had a comorbid mental health disorder or substance use disorder. And in fact, all of the admissions were the individuals had comorbid mental health disorder. So if there was no comorbid mental health disorder, there were, rate of 0% admissions. So all of the admissions were among individuals with comorbid mental health, and then high rates among the individuals with substance use disorders. Okay. And finally, the enrollees who received antipsychotic medication in the 30-day period following the diagnosis were less likely to have inpatient hospitalization. So here again, the 2.3% overall had a hospitalization. You don't see, the hospitalizations are actually a little bit lower among those who had antipsychotic medications. There's no real difference in terms of those who had office-based care. The admissions are slightly lower with office-based care plus psychotherapy. And then unlike emergency department visits, the inpatient admission was very high among those who received who were receiving intensive treatment. Again, these are descriptive. This is not intended to say that any of these types of care resulted in or caused the ED or hospitalization outcomes, but it does show patterns of care that help understand that kind of what's driving the service use. Okay, and then in the final set of analysis, we conducted a multivariable logistic regression analysis estimating the odds of each of the clinical outcomes, ED visits, and inpatient admissions, given the enrollee characteristics that we've talked about and the types of service use that they received in the immediate time frame after their diagnosis. So these analyses estimated the statistical significance of some of the observed associations that we talked about, while holding constant some of the other variables in the regression models. Okay, and then these are the treatment types that I described before. So these are the odds of the outcome, either an ED visit or an inpatient admission, relative to individuals who only received office-based care. So none of these defined treatment types were significantly associated with ED visits in the follow-up period. And you see that here, these odds of ED visits are not significantly different or higher than compared to individuals who received only office-based care. You do see significant association with ED use and substance use disorder, with individuals with comorbid substance use disorder having a 2.21 odds of having an ED visit in that following year. And like we saw, these are like we saw in the descriptive results, the individuals in the older age groups were less likely to have an ED visit, significantly less likely to have ED visits. On this side of this side of the table shows results for inpatient admissions, and so this is the odds ratios of these characteristics of the individuals and their odds of an inpatient admission. And these are similar to what we saw in the graphs, with individuals with intensive treatment being much more likely to have an inpatient admission, because there were the individuals with other comorbid mental health disorders also had a high rate of admissions also, but the models can't estimate a nodge ratio because there were 0 admissions in the among individuals who did not have a comorbid mental health disorder. Okay, and then I see that there are messages in the chats. I'm just going to give a quick summary of what we found. Again, these were descriptive, it's a descriptive study, and we looked at the prevalence of psychosis among Maryland commercial insurance enrollees ages 15 to 30 and examined patterns of behavioral health treatment following a diagnosis of FEP. And we explored how demographic characteristics and treatment patterns following a first episode diagnosis were related to clinical outcomes in the year following the diagnosis. The prevalence of psychosis was 0.34% in the population, and enrollees with psychosis had high rates of comorbid mental health disorders and substance use disorders relative to the general age cohort that was targeted in the study. They also were more likely to be males and reside in the more urban areas of the state. These results are generally consistent with findings from other studies that find higher psychosis prevalence among males and in urban areas and high rates of mental health and substance use disorder comorbidity. Most enrollees with FEP received some type of treatment in the year following their diagnosis. The most common types were pharmacotherapy, office-based visits, and psychotherapy. More intensive treatments were less common, particularly in the rural regions of the state. And just notably, despite the high rate of substance use disorder comorbidity, specific SUD treatment was rare, although as mentioned, these issues may be addressed in the context of their other services that they were receiving. The patterns of care by age group appear inconsistent with the basic tenet of CSC, which is to aggressively treat the first psychotic episode. We found that younger enrollees were treated more often with psychotherapy and less often with antipsychotic medication. And so this might reflect patient and family choice, with a hesitancy to initiate pharmacotherapy with antipsychotic medications at a young age. However, just noting that it's inconsistent with the clinical recommendations for treating FEP and the evidence that shows that early aggressive treatment can mitigate the progression to more severe psychosis and functional impairment down the road. And then finally, it did appear that the more complex and higher need beneficiaries drive ED use and hospital admissions. ED use is more common among the youngest age group and among enrollees with comorbid mental health and substance use disorder. And enrollees with SUD and more intensive treatment in the month following the diagnosis were significantly more likely to have inpatient admissions. Okay, and that's the summary. I think we have significant of time. Yes, I don't know.
Yep. Amy,
Yeah,
thank you
really.
so much. Really appreciate that presentation. So there were a couple of questions in the chat. One, I just did want to reiterate that this recording and the slides that Amy has will be available on the CRISP Learning System website. Their actual full report is already available. I did drop a link in the chat for those that are interested, but we'll get the other things up probably early next week. So Amy, there was a question, I think, that what you touched on a little bit about some of the data constraints, but they're asking if you tried to consider, or did you consider trying to identify those who are actually receiving CSC in Maryland, and could you account for any differences in services covered by insurances?
No, we were not able to get kind of at that level. It is notable that the urban rural differences, we were really interested across the state in terms of like what's happened in a region, because these services are available, right? So you would hope that they would be available to individuals living in those areas. It is the case that they're located, that in terms of their location, I actually think I have. They're located in the urban areas. So those urban and rural differences we're not attributing to CSC specifically, but that could be part of the difference, that they maybe had more access to the more intensive treatments because they were in the areas of the state that were served by the CSC programs. But no, it's not we can't identify them in the claims, and we didn't really, and plus that it's really too rare even to try to look at a hospital level analysis to try to figure out, well, did they potentially get to the hospitals that were providing the CSE? The numbers are really just too small to get down to that level, so we just kind of stepped back a little bit to take kind of a higher level view of just the patterns of care. And
Thanks, Amy. And we did have a couple other questions, and we do want to welcome if people want to come off mute if they need to elaborate, but I'll go for the chat for now. So we did have a question if there's a formal definition for intensive treatment, and if you happen to know if everyone is eligible to receive the intensive treatment, or are there any limitations to that?
so we defined those treatment categories, the intensive treatment, based on the procedure codes that that you see in the claims. And so what the intensive treatment included residential treatment or outpatient intensive treatment, as defined in terms of the how those procedures are coded and billed for, and also care coordination. So that is yeah, so that's how the intensive treatment was defined. It wasn't a specific type. It was just looking at beyond individuals who received care that was beyond pharmacotherapy and traditional office-based and psychotherapy. And I'm sorry, what was the second part of that question?
They were just wondering if
Covered by
everyone
insurance.
yeah.
Well, we can't really account for what, I don't know. We didn't look at insurance carrier level or to see kind of what I think most insurance companies probably cover some level. It may be more restrictive. There may be more prior authorization requirements, et cetera. So there's definitely the possibility and that the access to intensive treatment was restricted in terms of what type of insurance, and the requirements for being able to access those services.
Thanks, Amy. And we're gonna kind of bump back to a little bit of a follow-up question to that first one about the identifying CSC services. And there was a question of if you could rule out any billable services in a rural, or could you rule out that any billable services in a rural area was a CSC?
No, we cannot. I mean, it is possible that the services, we really just can't identify which individuals are specifically receiving CSC. I think the idea is that the research on there's really strong evidence of the effectiveness of CSC, and that wasn't really the goal of the study. The study the goal was really to look across the state and try to identify if the patterns of service use, it really was an exploratory an exploratory study just to try to understand what types of services and people are receiving. We really didn't have the capability to look specifically at outcomes related to CSC or any specific type of service. We also were hoping, like I said, we initially were thinking that we might be able to look at to conduct the analysis in Medicaid and Medicare. And so part of the idea was to try to see if there are different patterns for these different populations. But we ended up being limited to the private insurance. So I think there's some useful information here, but it's not, it's not. It really is more of a descriptive exploratory study.
Thanks, Amy. And I think you just touched on one of the other questions, but it was asking if this study did look at undiagnosed / untreated individuals or uninsured individuals.
Yeah, so CRISP initiated the study, and so we were limited to the private insurance data in the all payers claims database. And so no, so this really is the kind of tip of the iceberg in terms of individuals who came into contact with who had insurance coverage and came into contact with health services and got the psychosis diagnosis recorded in their claims. That's how they were identified. We do know that rates of psychosis are higher among Medicaid populations and uninsured populations, but they weren't part of the study.
Thanks. And looks like we have one last question in the chat, and it's, did the study examine the effect of conduct disorders, specifically as aggression might increase the need for inpatient and residential treatment?
No, we did not look at conduct disorders specifically. Again, once we kind of drill down to the first episode, the numbers start to get pretty small. I mean, I would assume that individuals who have conduct disorders and more aggressive, they're going to be more likely to come into contact with the health services, and so those may, I mentioned tip of the iceberg. So those may be kind of overrepresented here. But no, we didn't look at any specific type of, we didn't break out the specific type of mental health comorbidities.
Okay, thanks, Amy. That's all the questions in the chat. I don't necessarily know if everyone's going to have time to put in the chat, but I think there's some great discussion here. And as I mentioned, this is part of a larger Maryland Model Analytics project that CRISP is looking to continue. As you know, there are 3 additional sessions that are scheduled. We also have engaged sort of around 2 with some new vendors and Acumen as well. So there'll be some additional presentations and reports coming out probably towards the end of this year, if not next year. But if there is ideas about how we could follow up to the study or specific questions, as you mentioned, there may be some limitations with data availability, but I think we are very happy, especially given the engagement of this, to see if that's something that we can explore and partner with Acumen or another vendor to continue this type of research and dive deeper into these questions. So feel free to reach out to the learning system, to myself directly. I can drop my email in the chat, or if if you want to hop off of mute and ask it now, that's definitely an opportunity. And then finally, I did want to plug next week, we're doing the second session of this. So I'll put the registration link in the chat, but this is going to be a presentation about an evaluation of inpatient care and Medicare spending, specifically looking at Maryland's hospital's performance across different types of inpatient stays and comparing that to other states. So that is next Friday at 1 p.m. We hope to see you guys there, but it also will be recorded if you were unable to attend. Okay, so with that, again, thank you all who were able to attend, and we really appreciate your engagement here. Amy and Acumen, thank you so much. This was a wonderful presentation, and we really appreciate all of your effort in this analysis.
Thank you.
Okay, thanks everyone.